Again, thank you so much for being with us today. It's an honor and great pleasure to be among esteemed colleagues. My name is Khalil Al-Salem, Professor of Ophthalmology at Mu'ta University and Head of Department and Program Director. I'd like to thank our guests and panelists today, Dr. Lu'ay Al-Husseini and Dr. Rakan Haddad, for being with us, who are specialized in treating obstructive sleep apnea.
شكرا موضوع لك دكتور.
الله يحفظك حكيم. شكرا لك. So today I'm going to talk about obstructive sleep apnea, just an overview. We will discuss the pathophysiology, detailed ocular disorders that are associated with sleep apnea, and we will touch also on some of the aspects of how to care for CPAP, because caring for CPAP will help your patient more to adhere to the treatment, and hence you can help them achieve a better result. So what is obstructive sleep apnea? So this is recurrent episodes of upper airway collapse during sleep, characterized by intermittent hypoxia, hypercapnia, and sleep fragmentation. Typically, most of those patients, they have very noisy snoring. Sometimes the partner might witness cessation of breath, and it's closely linked to obesity, very wide neck, wide shoulder, abnormalities of the face, male sex, and advancing age. Chronic diseases like cardiovascular and neurocognitive disorders are highly associated sequelae of chronic sleep apnea. Epidemiologically, 1 out of 3 males and 1 out of 10 females have sleep apnea. It is thought that over 1 billion individuals are thought to have some sort of sleep apnea. The prevalence increase with obesity, metabolic syndromes, and sometimes if you have resistant hypertension, this can also trigger an alarming alert. High proportion of patients are, they remain undetected, and we believe that the ophthalmology clinic is a potential screening point for high-risk individuals, as we see a lot of patients in the early episodes. This is not the first lecture that I do actually on sleep apnea. I have a previous lecture. It's called The Vulture Eye. You can see it on YouTube. This is where a patient who came with subconjunctival hemorrhage, and actually after digging in the history, you find that he had severe sleep apnea, and he was actually very, very, very happy after starting him on CPAP. Things really improved for him, and it really changed his life. So there are actually syndromes that are associated with sleep apnea. And why do we actually talk about syndromes here, which is very unusual? Because in the ophthalmology clinic, as an ophthalmologist, I get a lot of referrals from my colleagues. The neuro department, the endocrine, rheumatology, the pediatric unit, all of them, they refer to me a lot of those syndromes. So, and it's very astonishing that, when you dig in sleep apnea and you find out that 50 to 80% of patients with Down syndrome have sleep apnea. For example, patients with connective tissue problems, Ehlers-Danlos, Marfan syndrome, they have laxity and easy airway collapse. So, they have a considerable percentage of sleep apnea. Over half of them, they have sleep apnea. Syndromes with a small jaw, a large tongue, micrognathia, macroglossia. So with facial anomalies like Treacher-Collin and Beer syndrome have also sleep apnea. So this is a very beautiful case report that it really touched me. Like, declining vision saved by tracheostomy. Okay, why do you need to wait for a patient, to get that bad sleep apnea in order to do tracheostomy finally for him. So this is a 37-year-old woman with Treacher-Collins syndrome. She was diagnosed with sleep apnea, and she has been treated with CPAP for a very long time. The patient was complaining of an increase in intracranial pressure, bilateral optic disc swelling, and features in the retina that is very, very similar to central retinal vein occlusion, as you can see here in this picture. So once tracheostomy was done for this patient, all these signs and symptoms resolved. You know, when you talk about, you know, middle-aged females, or let's say youngest females that have unusual increase in intracranial pressure and papilledema, doesn't ring a bell? Doesn't this ring a bell for you? Well, it actually does. Like, we have a lot of patients with idiopathic intracranial hypertension that comes to our unit. However, we do not screen those for sleep apnea. Why shouldn't we do? Why shouldn't we? We should actually. Like, you know, the word idiopathic doesn't mean, to me, it doesn't mean anything. I believe that everything has a cause, but we really need to dig for that cause. For idiopathic intracranial hypertension, maybe we really need to rethink that it might be sleep apnea. And the nice thing about that, we really need to rethink our strategy treating idiopathic intracranial hypertension. Okay, so other syndromes which have hypotony and obesity, like Bardet-Willey and Bardet-Biedl syndrome, also have sleep apnea, and the list actually is endless. Over 30, syndromes have sleep apnea. So all of these should be actually referred to a sleep doctor who will take care of them. Diagnosis of obstructive sleep apnea. Always they jump to the laboratory polysomnography, and I say no. As a doctor, you start with history and physical examination, and it's very important to screen for symptoms. If you have, if you think that they have the symptoms, for example, morning headaches, gastroesophageal reflux, presence of uncomfortable sleep, fragmented sleep, let's say retroocular pain. We have a lot of those patients, excessive dryness, as we will see now. So all of these actually it has to alert you that there is a problem, and someone else has to be involved in the management of this patient. So polysomnography is a test that depends on something called Apnea Hypopnea Index, AHI. So Apnea Hypopnea Index, if it's between 5 and 15, this is mild disease. 15 to 30, this is moderate, and in severe, it's more than 30. What does this mean? It means that the patient ceases breath for more than 10 seconds, let's say 30 times an hour, which is very considerable. And I mean by more than 10 seconds, it might be, for example, 20 seconds, 30 seconds, 40 seconds. It depends on the severity. So it's a spectrum of disease, and the severity even has some sort of complicated classification that, I would appreciate our panelists help us at the end of the lecture with it. So things really evolved regarding, diagnosis. So now we have home sleep apnea testing, which is portable and very easy, to be done. And nowadays, even our, smartwatches can detect sleep apnea. They have, an AI-assisted oximeter and snoring detection, which can help with some sort of algorithm that this patient might have apnea. Okay, so what is the pathophysiology of sleep apnea? First of all, intermittent hypoxia will cause oxidative stress, mitochondrial dysfunction. Sympathetic overdrive will cause elevation in the catecholamine, endothelial injury, and let's say dysregulation, along with systemic inflammatory cytokines that are released in the body. Okay, so like interleukin-6, tumor necrosis factor, C-reactive protein, all are actually released. And along with, with insulin, طبعا, the metabolic dysregulation will cause insulin resistance and dyslipidemia. So this is just a flow chart, rapid flow chart. You can see the intermittent hypoxia, increasing VEGF, which will end up with increase in the blood-retinal barrier disruption, and it will cause something similar to diabetic retinopathy. That's why we have actually patients that are very resistant to treatment. You know, you just inject them 20 and 30 times, and you just keep injecting and injecting and injecting, and it's not going away because there's something else that you have to look for. So sleep apnea gives a similar picture to diabetic retinopathy. Okay, so this is a very important thing to consider and keep in mind. So the pathophysiology of ocular, or let's say the ocular mechanism in obstructive sleep apnea, how does it cause ocular injury? First of all, it reduces perfusion and impairment to not just the optic nerve, but the whole eye. And as we will see, even the lacrimal gland is affected. The second, venous congestion, okay, which is caused by the increase in intrathoracic pressure, swings and alter venous return, the oxidative stress and inflammatory problem that we have talked about as well, and as well as the nocturnal intraocular pressure fluctuation. Actually, they get spikes of high intraocular pressure, which is, let's say, one of the causes to blame their morning headaches, along with the sleep fragmentation, which will cause pain, sensitization, and autonomous imbalance. So this is a picture showing the how obstructive sleep apnea can cause, through inflammation and oxidative stress, will cause damage to the trabecular meshwork, increasing intraocular pressure with time. And this actually rings a bell. You know, glaucoma. What is the most common cause of glaucoma? It's primary open angle glaucoma. And what does it mean, primary? Idiopathic. We don't know a cause. So why not really screening patients with glaucoma for obstructive sleep apnea? We may actually help those a lot. Actually, we have another category of glaucoma, for example, those with normal tension glaucoma, that we are very, very, very aggressive with treating, we're really aggressive treating them. We give them like, a lot of medications and so forth, and still they deteriorate. This should alert us that this might be sleep apnea, and they need to be referred. So the oxidative stress causes mitochondrial dysfunction, and this further cause a problem to it causes optic nerve damage as well as retinal damage. Now, finally, the increase in intracranial pressure will cause an increase in the episcleral pressure, and this will further cause further damage to the optic nerve, along with the vasoconstriction that happens due to the high systemic blood pressure, also will cause ischemia to the optic nerve. So this actually rings a bell that the ischemic theory of glaucoma is very feasible. The catecholamine and a vicious circle. Obstructive sleep apnea triggers recurrent surges in the sympathetic tone during apneic event. So this will cause elevation of norepinephrine and epinephrine, and this will lead to chronic hypertension, vascular stiffness. And the problem is that when we have nocturnal hypotension, hypertension swings, this increases the ischemic events of central retinal vein occlusion, central retinal artery occlusion, and non-arthritic ischemic optic neuropathy. Herein, I'm going to talk about the ocular problems that are caused by obstructive sleep apnea, and I have actually, let's say, categorized them, or I'm listing them according to the level of evidence. So we have level 1 evidence that obstructive sleep apnea causes ocular surface disease and floppy eyelid syndrome. This is well known and written in books. So there is high prevalence of dry eye disease, and most of the tests showed that the Shermer score, okay, there is a reduction in the Shermer score in patients with obstructive sleep apnea, as well as meibomian gland dysfunction, which improves after CPAP. So the story of CPAP, along with the tear film, is not that easy. You know, CPAP, true, it does increase the blood flow to the lacrimal gland, and it helps the patient to, achieve a, let's say, better Shermer. However, sometimes if we have an air leak, okay, it might also cause some dryness and some ocular surface problems. So we have a lot of data here, but if you are adherent to the CPAP and you're doing it the right way, things should work for your patient just fine. Glaucoma and obstructive sleep apnea. This is level 2 evidence. Why? Because we don't have a lot of studies that really correlate glaucoma to obstructive sleep apnea. Simply, I guess it's maybe money driven. There is not a lot of let's say companies that are interested in the subject, so you won't really find a lot of studies. But there are actually some there that correlates glaucoma to obstructive sleep apnea, and we have 2 pilot studies that showed that the retinal nerve fiber layer, okay, which is the axons of the ganglion cells, are actually thinned out and lost because of sleep apnea. And once actually you start patients on CPAP, things start to improve. I personally have one of those pilot studies. I have 12 patients, and I really find that using CPAP for 3 to 6 months improves your nerve fiber layer thickness and the total retinal thickness by around 30%, which is really high. Glaucoma and obstructive sleep apnea mechanism. So we said that, you know, intermittent hypoxia will cause endothelial dysfunction, and the nocturnal fluctuation in intraocular pressure also causes further burden on the optic nerve. Okay, along with the sympathetic surge and blood pressure variability, also decrease the perfusion to the optic nerve further, causing the disease, which looks like glaucoma or glaucoma. Okay, so we talked about the OCT and OCTA findings here. Non-arthritic ischemic optic neuropathy and CRVO and CRAO, central retinal artery occlusion and vein occlusion, also has been linked to obstructive sleep apnea. And CPAP therapy should be recommended for any patient who was confirmed to have, let's say, sleep apnea. Especially, or let's say, let's take it this way: if you find a patient with central retinal vein occlusion or central retinal artery occlusion with no other risk factors, for example, they don't have ischemic heart disease, they are young patients, bilaterality of the disease, always should alert you that you really need to screen your patient and start him on therapy with a specialist. Age-related macular degeneration has been also linked to obstructive sleep apnea, and this actually explains the high VEGF. Diabetic retinopathy worsening has been documented in several studies, and now there is really growing number of literature after 2021, stating that you really need to screen patients for sleep apnea if you have resistant, patients to treatment. Hemoglobin A1C is not going down. You just blame your patient. You should have better control and so forth. But they're actually, you have to believe your patient. Like he's doing everything that he can do in his hand, but he's not improving because there's something missing. Okay, so better oxygenation of the retina will help the retinopathy to improve. Central serous choroidopathy. This is associated with, obstructive sleep apnea has higher incidence of CSR, and it's, they really share a common pathway, like the sympathetic overactivity, cortisol dysregulation, and the high catecholamine in blood. Treating patients with obstructive sleep apnea patients might help those patients, those category of patients. Depression and anxiety. Why did I actually, put that slide? It shouldn't be. I'm an ophthalmologist. However, most of those patients that come to you, they are really furious. They are actually the worst to deal with. Simply, a depressed and an anxious patient can hit in the face. They don't have any problem with that. What I'm saying, be gentle, be calm. Sometimes you can convey to them really bad news. Wallah ya Hajj, you have sleep apnea, go to that doctor, he will help you. They need more explanation. Sit down with them, try to help them, get the right, let's say, notion of things so that they can, have a better safe landing. Like even, me in my position, maybe I was able to refer 10% of my patients to the right doctor. 10%, because 90% they just say, like, what the heck are you talking about? It's nobody shared the notion, nobody shared what you are saying. Okay, now we are going to talk about signs and symptoms, very common, that happens in obstructive sleep apnea. So morning headaches and migraine usually improves a lot with CPAP. Gastroesophageal reflux, trigger finger, and other systemic features. For example, morning stiffness in the hands, knee, back pain also can really improve after CPAP, which has been very documented in literature. I have this hypothesis, very strange one. Like, I believe that, because of the fluctuation of the intraocular pressure that happens in the eye, especially if the patient was so young, like, below 10 years of age. I was actually thinking of correlating progressive myopia. Like we have those patients, they are like in their 5 and 6 years of age, and they have like minus 15 degrees of myopia. So, I just, thought that would it be a good idea to refer them to a sleep clinic? Maybe we might find a cure for them. This needs, more, more studies and to look into it. And clinically, we have also clinical red flags that should alert you that there's an undiagnosed obstructive sleep apnea. First of all, normal tension glaucoma patients. We talked about that. Those patients should be referred. Non-arthritic ischemic optic neuropathy, especially if it's bilateral, young patient, non-diabetic, no other risks, recurrent central serous choroidopathy, recurrent central vein occlusion, central artery occlusion, disproportionate severe diabetic retinopathy with a relatively normal hemoglobin A1C, combination of dry eye, morning headaches, obesity, loud snoring, and daytime sleep. So how can we apply screening for sleep apnea in the ophthalmology clinic? So there are actually two screening tools that I will be distributing, hopefully in the clinic. There's something called Stop Bang, and the other one I can't recall now. It has all those symptoms that we were actually discussing. So there are actually some abnormalities along with obesity, resistant hypertension, atrial fibrillation, and gastroesophageal reflux. Those also are symptoms that you should actually look in your history before referring your patient. Right. What is CPAP therapy? Continuous positive airway pressure is a method that allows patency and prevents collapse of the airway, especially when the patient is inhaling, especially in inhalation. Okay, because if the patient is in deep sleep, most of the laryngeal muscles, the pharyngeal muscles will, let's say, it will relax, and the tongue will close the airway. So this is where actually apnea happens. Now, what is the CPAP machine? What does your patient look like actually during sleep? It's very easy to tell someone, okay, you need a CPAP machine, but this is actually how they will sleep every day. Okay, all these tubes with this machine, and every night, but it really makes a difference. Now, this machine needs real care. Sometimes, with all due respect to our colleagues, they really don't have time to give to our patients. But our patients actually start with CPAP. They're very happy. Things really improve. But after a week or so, things start to decline. Why is that? Simply because the reservoir, this whitish area here, which is filled with fluid, is not cleaned regularly. This actually fills with slime. And this slime is actually fungus, okay, which can cause upper respiratory asthma-like symptoms, and patient starts to cough. Another important thing, there is a very tiny little filter that needs actually to be thrown away every month. This is a very important tech that will actually prevent your patient from continuing their apnea treatment. The problem, the final one is actually cleaning all this tube system. This also has to be cleaned, and even sometimes cleaned with vinegar in order to get a better care of the system. We talked about improving adherence. Really you have to communicate with a specialist. So that's why we have Dr. La'i Al-Husseini and Dr. Rakan Haddad today, who will help us really and teach us how to adhere, how to improve the adherence of our patient to CPAP. So I will leave this part to them. And really this part of medicine, it's really neglected. For example, in my GP years, I've never actually been exposed to sleep apnea. Nor, we, as ophthalmologists, we were, let's say, talking about this subject, although we have a lot of literature that was published, not in ophthalmology journals, but in sleep journals, which we never read. So take-home message. Obstructive sleep apnea is a common, underdiagnosed, and has a major implication for ocular health. eye glaucoma, retinal problems, diabetic retinopathy, and CSR are meaningful associations. CPAP offers systemic and ocular benefits, and the ophthalmologists are uniquely positioned to identify patients at risk and trigger sleep evaluation. And always, you go hand in hand with your sleep doctor, because they really give great aid in helping our patients. And I thank you so much for being here. And I give the floor to our panelists now. Dr. Haddad, Dr. Luay, if you want to take it from here.